I am Ruth Katz, Executive Director of the Health, Medicine, and Society program here at the Aspen Institute, and we are, I can't tell you actually how terribly excited we are to be kicking off this inaugural public health grand rounds with such a dynamic speaker on a very timely topic. But before I introduce our first session, let me just take a moment or two to tell you about this event. As many of you know, Grand Rounds is a time-honored feature of medicine designed to keep clinicians up to date about scientific and medical advances and promote excellence in research and practice. This year, and hopefully going forward in the future, we are borrowing from that tradition to advance knowledge about the cutting-edge issues in public health. Public Health Grand Rounds is a partnership between two Aspen programs, Health, Medicine, and Society, which is has a domestic focus, and the Global Health and Development Program, which of course works internationally. This series is made possible with funding from the Aspen Venture Fund, for which we are very, very, very grateful. We'll be organizing Public Health Grand Rounds 4 to 6 times a year, taking full advantage of our prime location here in Washington to engage influential thinkers and doers in the field. This is an invitation-only event, and we've asked all of you to join us because we believe you can take forward-focused ideas that you'll be hearing about and spread them further. As you can also see, we're videotaping this talk, and it will be up on our website within the next 24 hours. Feel free to share that with colleagues, or if you'd like, watch it again. And now it is my great pleasure to introduce our kickoff speaker, Dr. Jeffrey Brenner, who will be talking about healthcare hotspotting. His use of data to map so-called hotspots where the highest consumers of healthcare can be found, like the guy who was hospitalized 100 times, more than 100 times in a single year. Hotspotting is driving new approaches that encourage more effective and less costly team-based care. And after Dr. Brenner's presentation, we've allowed plenty of time for your questions and comments. Dr. Brenner is Executive Director of the Camden Coalition of Healthcare Providers in New Jersey, which he founded in 2003. The coalition brings together hospitals, providers, and community residents to build an integrated health delivery model for residents of Camden, New Jersey, which is one of the poorest cities in all of America. Trained as a family physician, Dr. Brenner is also medical director of the Urban Health Institute at Cooper University Healthcare, which uses modern business techniques to deliver better and less expensive care to underserved populations. His work was profiled in The New Yorker by Atul Gawande in 2011 and featured on Frontline that very same year. He is also a recent winner of the legendary MacArthur Fellowship, known to all by its much more colloquial title, the so-called Genius Award. It's my great pleasure to introduce you to, and let us all welcome, Dr. Jeffrey Brenner.
Thank you so much. It's such a pleasure to spend time with you, and thank you to the Aspen Institute staff for inviting me. We're going to spend a half hour talking about healthcare in America, and specifically using Camden, New Jersey as an example, and we've got plenty of time for question and answer. Let me do a little bit of definitions first. For me, healthcare hotspotting is using techniques that Bratton used in New York City to redesign and rethink policing in America. So hotspotting is not making maps. Hotspotting is using data sets to find outliers, with the idea that outliers are often the canary in the coal mine. The outliers will tell you about the failures in a complex adaptive system. So many people have described Bratton's innovation in New York City as making maps. And Bratton's real innovation was the recognition that policing in New York was failing because it was a large, unaccountable, expensive bureaucracy that was very hierarchical, in which authority was at the top of the institution, at the top of the chain of command, but responsibility was utterly diffuse. And a decision had never really been made within the organization about who the accountable manager was, which is a very basic business construct. And if you have an accountable manager, what's the unit of accountability and what's the denominator? So let's break that apart. So he realized that in New York, the best unit of accountability would be the precinct. So policing is organized in precincts. And the accountable manager would become the precinct captain. But in order to be held accountable, you've got to have data that's running day to day, week to week, month to month. So he pulled all of the precinct captains together, and he gave them authority So a very basic idea in American business is to push authority down and also push responsibility down. So typically what would happen in the police department is if there was a failure in policing, they would take authority away and they would make responsibility very unclear. So instead he pushed authority down to his captains, and every week they had to stand in front of maps, graphs, and charts with all of their laterals, the other captains, and defend what they were doing to redesign and rethink policing within their precinct. So his innovation was not hotspotting, making maps. His innovation was instituting the managerial structure to make use of that data day by day, week by week. So the reason I'm segueing into this is to make the point that hotspotting is not making maps. Hotspotting is the strategic use of data to focus in on outliers. And most of our public systems do a terrible job of responding to the day-to-day, week-to-week, month-to-month needs of outliers. So in a typical classroom, there are a few kids with differential learning styles, and the system just can't pivot to their needs. Within a typical school, there are a few parents and families that are in the principal's office all the time, and that school's just simply not set up to meet their needs. Within a typical community, there are a small number of people committing most of the violent crime, and historically, policing did a very poor job pivoting day by day, week by week to target those people. And in healthcare, we do this as well, that a small sliver of patients are responsible for much of the costs, but we really ignore them. And any of you could become an outlier in healthcare. Any of your family members could become an outlier in healthcare as well. It's not just the poor that this is impacting. So let me start out by talking a little bit about how I got started in this. My dream was to be a frontline Medicaid provider, and this was my office in Camden. And I lived in Camden as well, so I lived there for about 8 years. And this was a small 3-exam room office, seeing kids, adults, and I delivered babies at the local hospital. It is an incredible focus group in all of healthcare's failures, because all of the healthcare failures eventually stumble into my office like this. This is my office today. It's currently boarded up and closed. And the reason it's boarded up and closed is that my payment rates kept being cut. So by the time I closed my office, I was being paid $19 to $35 a visit. At the same time, we tripled the size of our emergency rooms. We built new wings on the local hospitals. And we bought more machines, more gamma knives, more stuff in healthcare. And we hired lots of new specialists in Camden. So the fun thing about such a small city is that you can see all of the variables play out in really concrete ways. You know, in Medicaid particularly, it's a fixed pot of money. So if you're spending more on a certain set of things, you're inevitably going to spend less in another set of things. So, so the reason this is important is that we have tremendous Medicaid and healthcare expansion now. We already have relatively low numbers of primary care providers. Kids don't want to go into primary care, and zealots like me can't even keep our offices open. So, you know, I think the state one day will regret the day that my office closed because it gave me more time to come and complain to people like you. It would have been cheaper, maybe better for them just to leave my office open and keep me absorbed. This is how the Camden Coalition began. Very humble origins. We had no grand vision. It was a health provider breakfast group. So literally this was community organizing in my community of grumpy, miserable primary care providers, getting together and having breakfast every quarter. And after doing that for about 3 years, we formed up into a nonprofit, then invited the hospitals, the FQHCs, behavioral health, addiction, and even patients onto our board. So I run a membership nonprofit. That's a very unruly thing to run that makes all of its decisions by consensus for 12 years between stakeholders that hate one another, that are highly competitive. 3 local hospitals that are very competitive over market share, but none of them are fighting over more market share in the city of Camden. So that's the only reason we've been allowed to get away with what we're doing. If I was doing what I'm doing in your community, I wouldn't be standing here. I would have been closed. So the only reason I'm getting away with delivering better care at lower cost is because no one cares about poor people and no one's fighting over more market share of poor people. So one of the things we managed to do is get data from all 3 institutions. And this is a little bit like collecting data from Target, Kmart, and Walmart, and combining it, their customer data, and combining it into one data set, and then methodically working to get rid of their customers so they don't come back. So, you know, this is data directly from the hospitals that we've collected over a 12-year period. It's the name, address, date of birth, date of admission, charges, receipts, and insurance status of every Camden resident. This is big data before anyone used the term big data. And for about 7 years, this was kept on two $50 hard drives with open source encryption, password protection, a desktop computer, and desktop software. We used Microsoft Access for 11 years to analyze this, and we finally broke it. You get to a certain point where there's too much data for it. These are the maps and graphs you're about to see are things that have been done by 20-year-olds. We didn't have any money to do all this. We pretty quickly learned that half the population uses an emergency room or hospital in 1 year, that someone went 324 times in 5 years, someone went 113 times in 1 year. Someone in the city of Trenton, where we have a sister organization, a single patient went 450 times in 1 year. 450 times in 1 year. The total amount of money paid to Camden hospitals is $108 million a year. So are there any taxpayers in the room? I want to thank you for the best economic stimulus plan Camden has ever had. It's been an $108 million economic stimulus plan a year. It's been great for the city. We're building new hospitals with the money that all of the taxpayers in the room are investing. And the question is, are you spending your money well? Because it's so poor, the vast majority of the money being spent is Medicaid, Medicare. These are publicly funded programs. The most expensive patient had $3.5 million in receipts, and 30% of the costs go to 1% of the patients, 80% to 13% of the patients, and 90% of the cost to 20% of the patients. That's true everywhere. This is not just a fact that's true in poor communities. Even in an employee pool, within an upper class community, middle class, small percentage of people are driving much of the costs. The number one reason to go to an emergency room in Camden is head colds. There were 12,000 visits for head colds in a year. In a 5.5-year period. Otitis media, ear infection, viral infection, sore throat, asthma, stomach virus. I can tell you exactly what the hospitals make for this. They get paid $150, $300, $400, $500 per visit. It's actually quite a moneymaker. The vast majority of patients who go to emergency rooms in America have insurance, and they have insurance cards. These are poor moms and kids who can't get appointments. If you've ever had a hard time getting an appointment, imagine what it's like to get an appointment in Camden. This is a segmentation of the data. This is a map of 5.5 years worth of data of Cooper, Lourdes, and Virtua overlaid onto the map of the payments to the hospitals. So this answers the question of where do the expensive people live? So this is only 9 square miles, very small geography. 6% of the city blocks are 10% of the landmass, 18% of the patients, 27% of the visits, and 37% of the costs. So these are the two most expensive buildings in the city. Building at the top is a building full of dual eligibles. These are elderly and disabled patients who have both Medicare and Medicaid, 600 patients with 12 million in receipts. Building at the bottom is a subacute rehab and nursing home, 300 patients with 15 million in receipts. To go back over and over, we've spent a lot of time in these buildings. We actually have patients from the building at the top on our board. This is not about the patients. This is about a very broken delivery model. We've done similar mapping now in about 10 different communities, many hospitals, and found the same pattern everywhere we've looked, middle-class areas, rural areas. So this is data from Newark showing similar patterns. Data from the state of Maine, that as you get older and sicker and more disabled, it's hard to live in the middle of nowhere. So this is the kind of data that Procter & Gamble uses, right? This is just classic business segmentation. We don't use healthcare data in any ways like this. This is not a common use of healthcare data. We use the data to figure out where to put billboards up so that you can figure out how to get people into your orthopedic, program. That's the only part of a hospital using strategic use of data to figure out how to connect patients with services. This is the CAT scan of a middle-class woman with a master's degree. And this woman, within a 5-hospital connected system, integrated system, fully electronically connected with an Epic system, had 102 emergency room visits, 54 admissions, 147 CAT scans, 73 CAT scans of the head over a short period of time, a couple of years. That is an abnormal CAT scan, but it didn't take 73 of them to determine that it was abnormal. All the doctors had to do is click on a button to find out all of the previous CAT scans. This is all within one system. This is not moving across systems. A group of family medicine residents found this case, got very involved. They were hotspotting, which is really a form of root cause analysis where you go out and meet these people and figure out where's the service delivery failure. And it turned out that she just had severe anxiety and was quite overwhelmed with some of her issues in her life. And they did home visits. They got to know her well. They really deeply engaged with her. They have a psychologist in their program that began to work with her, and she just stopped going. So that's healthcare in a nutshell, which is too much of the wrong stuff. It costs too much money. And unfortunately, until you're caught in this system, you don't even realize it. And in some ways, it's a consequence of our incredible success. The biomedical revolution has been incredibly successful. We can transplant your organs. We can pull you back from the brink of death. We can cure your cancer now. That's amazing. We should be really proud of that. What we can't do is stop ourselves. We just keep doing more and more and more and more. So we have a failure of complexity where we can't get out of our own way, and you or your family will probably have some moment in your life where you experience how complex the system is. This is an example of a single patient, 55-year-old male, admitted with a GI bleed and shortness of breath, stomach bleed. This is a dual-eligible patient. In 6 months, had 9 emergency room visits and 6 admissions to the hospital, 12 meds a day, has kidney failure, kidney cancer, hepatitis B, high blood pressure, high cholesterol, has blockages in his arteries, asthma, glaucoma, sleep apnea, and severe back pain. This is a sort of a care map, a visualization of this patient's care. The patient's in the middle, and each circle is one of the services that touch the patient. So the patient, we picked the patient up right at the bedside. So we have outreach teams that go right to the bedside and engage people. We followed him out to subacute rehab and then worked with him because he got readmitted to hospital number 2. We had to coordinate home nursing, home PT and OT, transport, meals, durable medical goods, dialysis, nephrology, transplant. The poor primary care provider paid $19 to maybe $40, $50, had to coordinate primary care, had to coordinate ophthalmology, pain management, GI, cardiology, urology, oncology, and surgery. We are really far away from solving that problem. We may not solve that problem in my lifetime. This is a multi-layered problem that goes to the core of how we frame our services, how we train our providers, how we pay for care, how we move data around. And we're just at the very beginning of starting to think this problem through. So to be clear, none of the people in these circles, none of the doctors are trained to collaborate, play nice, and work in teams. We don't even really understand what's driving utilization in healthcare. We have laws that make it difficult to move the data around. We have payment models where each of these circles would go out of business if they did the right thing. And we're beginning to move through this, but this is a very tough problem to solve. These are the crazy piles of medicines you find in people's homes. We have a bag of meds that's worth $50,000 of meds that were started and stopped by the local hospitals. And this is a visualization of the patient's data. So this is time. Red line is an inpatient stay. A blue line is an ED visit. So 1 year pre-enrollment, this patient had $300,000 in charges. Those are bills sent out by the 3 hospitals just in Camden. $59,000 in payments that came back to the hospitals just for the hospital part of his care, not the doctor part. 24 inpatient days and 2 ED visits, and he stopped going after we began to work with him. And let me introduce him to you. This is Glenn. Glenn gave us permission to tell you a story. He has since passed away from his kidney cancer. And in the middle is Corinne. Corinne is a young AmeriCorps volunteer who now works at this FQHC running their care coordination program and is thinking about going to either public health school or nursing school. On the left is the patient's primary care provider, and on the right is one of our nurses, Jason. It turns out that a lot of this work can be delegated to a whole variety of words that are being thrown out now. Patient navigators, health coaches, community health workers. There is a constellation of unlicensed people who can do a whole lot of this work, but they have to be trained, they have to be supervised. You can't just put them out in the community. This is very hard work to do. It's very hard work to organize and hard work to manage. This is a 52-year-old woman, Spanish-speaking, admitted for shortness of breath, lives with her family. She had 6 inpatient visits in 6 months. She lives on a ventilator and has severe lung failure. So once again, this is time along the x-axis. The pink side is 1 year pre-enrollment. Blue side is post-enrollment. Each of the red lines is an inpatient stay. So what this tells you is that this patient had a 6-day stay. A week later, came back for a 4-day stay, a 7-day stay, a 10-day stay, 11-day stay. Just kept coming back every week. Had $745,000 in bills sent, $95,000 in payments just for the hospital portion of this patient's care, just to Cooper, Lords, and Virtua in this period of time, 55 days in the hospital, 1 emergency room visit, and she stopped going after we started working with her. She hated the hospital, but her family was terrified of the ventilator. So her name is Lillian Perez. This is her graduation diploma after working with us for 90 days. And Corinne is on the right. Corinne is also an AmeriCorps volunteer. I'm sorry, Ashwin. Corinne I introduced you to already. Ashwin on the left is currently in med school. You know, in some ways my only hope for my profession is that we get them before they even get to med school, because the curriculum taught in med school will make your understanding of this problem worse. It does not train people to understand what's really going on. So we have a whole lot. We have 10 AmeriCorps now. 9 of them are pre-med. So I think my best way of shifting the system may be getting them before they're even in the system. So Lillian's family was terrified of the ventilator. If you can imagine, you had a relative in your house living on a ventilator. So they got her transferred to a medium care unit where they did a lot of training with the family over a 2-week period. And then they built a care team with the pulmonologist and the primary care provider so that they were both on the same page. And she stopped going. We drive all of our work from a health information exchange. So one of the things that our nonprofit runs is a health information exchange. So across the region, I have real-time data coming in on demographics, hospital utilization, labs, radiology, and hospital discharge summaries. That's a very powerful data set, and we export that data every day to drive our work. So this is a citywide hospital census combined across all the hospitals, because high-cost complex patients, even middle and upper-class patients, bounce from hospital to hospital. That's why you have to connect the information across the hospitals, which flies in the face of our current model. Our sort of market-driven model of competing hospitals makes it very difficult to create robust care coordination models where you actually have to get them to cooperate across the institutions. So let's talk briefly about why saving money is so hard. Boy, it's hard. I mean, if I had any idea how hard this is going to be, I don't know I would have started on this project. First of all, we don't even have a field of thought to embrace what needs to be done. This is not public health. This is not health care. Some people are calling it population health. Population health is neither health care nor public health. It's actually probably 6 or 7 different disciplines squished together. So if anyone's a fan of E.O. Wilson, he wrote a wonderful book called Consilience. It's a consilient field, which is a combination of many different fields. It's a mix of anthropology, sociology, psychology, developmental biology. There's a mix of nonlinear math, systems engineering, and business thinking to even begin to solve the problem. And none of those fields know how to talk together. We don't have collaborative frameworks in which to work on these kind of problems. It looks much more, if you know the history of Xerox PARC. Xerox put a research lab together out in California with a mix of anthropologists, physicists, systems engineers, a whole variety of different professions. And they invented the mouse, they invented the GUI interface, the laser printer, CD-ROMs. Then they gave a tour to 2 really nice guys. Anyone know who they gave a tour to? Steve Jobs and Bill Gates. And that's the whole, the whole Mac framework and the eventual incarnation of Windows came from there. But it was a very fertile place with a mix of skill sets. I think that's what population health is, but we haven't even really begun creating it. If I say chemistry to you, you say the periodic table. If I say physics, you're going to say force equals mass times acceleration. If I say, anthropology, you may say Margaret Mead and a whole framing around observer. We don't have the same frameworks yet in population health. And so our definition of population health is better care at lower cost for everyone every day. Better care at lower cost for everyone every day. Everyone doesn't need the same thing every day. So that immediately brings into mind not predictive modeling, but surveillance. And it also brings into mind segmentation, because you need to discreetly put people into different categories, surveil each category, and figure out how to meet their needs. It also brings up ideas of system engineering and sort of fundamentally restructuring how these service delivery models work. It brings in ideas around engagement, using ideas out of addiction, behavioral health, things like motivational interviewing, harm reduction. It's really an encompassing of very different frameworks than we currently use. So our thought and what we've observed in Camden is that you have to have three things to fix anything in healthcare or in population health. You've got to have deep engagement with patients, families, providers and practices, and with communities as well. That's very hard to pull off. Clinical redesign, which is box-by-box redesign of workflows using modern operational business techniques, and data in ways that we don't currently use data. It's also really hard to solve this problem because this is an existential moment for the healthcare industry where doing the right thing will put you out of business. And not a lot of nonprofits or for-profits are wired to put themselves out of business. So, this is a moment like Blockbuster Video experienced when some executive in the executive team, probably younger executives, came to the leadership team and said, people are beginning to rent videos online. And Blockbuster Videos, was making so much money from you going every Friday night to the video rental store and arguing with your spouse and walking from aisle to aisle to aisle that they never changed their model. And at the last minute, they implemented an online rental program that didn't work. They were too late to the game. And they're a penny stock, they're bankrupt, stores are closed up all over the country. That's disruption. And better care for your family is disruptive to the healthcare system. Better care at lower cost is disruptive. And the work we're talking about is very disruptive. The other reason why we are really far away from solving this is the fact that no one in healthcare knows about this study. So let's do a survey here. How many of you have heard of the ACE study? ACE study, Adverse Childhood Experiences Study. And how many of you are involved in healthcare? So everywhere I've gone, I've had audiences with like thousands of people in the room that are ACO experts, healthcare experts, and no one has heard of the study. And after we're done, I think we should untangle why, because I think that's a very interesting question. So a wonderful researcher at Kaiser Permanente in California, who's a physician, was an obesity researcher. And he started to notice that when patients in his obesity studies, women lost weight, they sometimes gained it right back. And as he started to untangle this, he began to realize that a lot of them had been victims of sexual abuse. And as they lost weight, they began to get unwanted attention. So that led him down a chain of causality to create a survey that's an instrument that you can download and look at. That's called the Adverse Childhood Experiences Survey. And it asks you questions as an adult about the horrible things that happened to you as a kid. He mailed the survey out to Kaiser Permanente patients, 17,000 of them, and 70% answered the survey. Can you imagine? And they even agreed to have it connected to their medical records. This is highly statistically significant. This is a really big deal. And it turns out that when they created a point scale, and when you add up the number of categories of adverse childhood experiences you've had, death of a parent, physical abuse, sexual abuse, one parent hitting another, whole categories of these things, not how many times you had it happen, just the existence of the category, it's the best predictor we have ever found for health spending, health utilization, for obesity, substance abuse, smoking, alcohol, for poorly controlled chronic illness, and for out-of-wedlock teen birth. It's also highly predictive for IV drug use, severe chronic intractable homelessness, for being in a prison. So that's a pretty big reframing of what we're seeing in society and what's going on, and has had a deep and profound effect on our work in Camden as we have come to realize that hospitals in America, hospitals in Camden, are filled up with people who had really shitty things happen to them in childhood. And what we're doing is saying, Mrs. Rodriguez, you have to do what I tell you to do and start being more compliant and more adherent. We're wagging our finger at them. And we're asking the wrong question. So instead of asking what's the matter with you, we need to start asking what happened to you. And that's, I think, a deep paradigm shift. The other thing that we have not figured out even a language is how to be both effective in healthcare and efficient. Effective and efficient. So the axis of effectiveness in healthcare is relationship building. Really effective doctors and nurses build really strong relationship with their patients. Their patients really like them. But being efficient is a very different skill set. That's about keeping the trains running on time. And we have a fight in nursing, in medicine, all over healthcare. And we have a fight in other fields as well over being both effective and efficient. So the doctors bang their fist on the table and they say, I can't see people in 15 or 20 minutes. You bean counters are ruining the practice of medicine. And then the folks that have to pay the bills and make sure that people can get in to see someone and get an appointment are saying, we got to keep the trains running on time here. Like, you guys, you can't spend, 40 minutes in there with that patient. So we have this fight in all kinds of ways back and forth. And a breakthrough in healthcare is when you do both well. And we're spending a lot of time in my organization to get to the point that my warmest and fuzziest social workers and nurses can bang on the table and say, are we being efficient? And my most genius, brilliant operational people with MBAs can say to the nurses, are we building relationships? And talk across disciplines in this way. And I think that's where some of the breakthroughs happen in healthcare. So I want to close with something that Clay Christensen has talked about in his writing, which is really, I think, the shift that healthcare is in the middle of. We're about to industrialize the American healthcare system, and it's going to hurt. And our Luddites are going to hate it. So industrialization often starts with things being made in workshops, where artisans and craftsmen make beautiful things that are very expensive, that are non-standard, and when they break down, they're hard to fix and hard to replace, and only the wealthy can buy them. So in the early days of the auto industry, cars were very expensive and they were works of art. Henry Ford came along and standardized, protocolized, stretched that out onto an assembly line, and you went from being a craftsperson, an artisan, to just putting tires on every day. Really dehumanizing work. But your wages went up. You, on the assembly line, could now afford to own a car. The cost of the car went down, but you can only buy a black Model T. That was it. In late-stage manufacturing, in the Toyota model, to be an employee on the assembly line, you have to have a lot more education. The engineers are coming down talking to you. These are team-based models. A lot of the boring work's been automated. There's a lot of delegation, standardization, much higher quality, much lower cost for what you're getting. That's what we're in the middle of in healthcare. And we're way over on the left still. We're stuck, with our artisans fighting every step of the way. So very challenging moment, and I'm sure we'll talk about that more. So I want to wrap up in the last slide here, which is to let you know that the Fountain of Youth has been discovered in Doylestown, Pennsylvania. You thought it was going to be in Florida, maybe Orlando or something like that, or Miami or Fort Lauderdale. This is also work that almost no one knows about, which I think is also interesting. Work done by a really brilliant physician and a whole team of folks that have been working on this, a guy named Ken Coburn. And he's been working for many, many years on this model. And it targets very high-risk, middle-class, elderly Medicare patients who are in their 80s. And it's a randomized controlled trial sponsored by Medicare. And it's been going on for 10 years, 17,000 adults over 65. The Mathematica did the analysis, has been monitoring this. And what they found is that having a great nurse that's highly trained, it takes 9 months to be trained into the model, going out every week to check in on your mom or your grandmom, reduced the risk of death by 25%. There's no pill I can give you. You have to go back to iron lung and the polio vaccine to get these kind of rates. When we treat your cholesterol or we do a mammogram, like, you have to treat hundreds and hundreds and hundreds and thousands of people to impact one person benefit. So, like, you don't normally see these kinds of rates in modern medicine. This is like hand washing. For the high-risk patients, these are 80-year-olds with 3 chronic illness. They had a 48% reduction in their death rate. That's just crazy numbers, just from a nurse in a highly trained, structured model. They had a 33% reduction in hospitalization, 22% reduction in total cost to Medicare. And Medicare has tried to pull the plug on this thing at least 6 times every year. I don't know if people saw last year, Ezra Klein did a Washington Post article on this, but this thing keeps having a near-death experience every year. So I think that's a great place to stop. We've got lots of time to debate and talk.
Thanks, Jeff. I think we could listen to you all day, so I don't want you to stop talking. This is our first in our Grand Round series, and so this is all about questions. This is all about your questions. So let me open up the floor, and you maybe can just go.
Peggy Clark. Introduce yourself.
Forgive me. I am a friend of Ruth Katz. My name is Peggy Clark. I'm Vice President of Policy Programs at the Institute and head of the sister program that focuses on global health and development. And Ruth and I together and our colleagues are launching this Ground Round series, of which this is the first, and this couldn't be a better opening for it. But we very much like to open the floor to questions in true Aspen tradition. If you could raise your hands, and we have microphones to bring to you.
Hi. Hello? Hello. Can you hear me? My name is Michael Chetta. I'm an emergency physician. And so I think I've admitted a couple of those patients that you talked about. One of the things that strikes me most abundantly about healthcare, I only work in the hospital setting, of course, is if there's 4,500 hospitals in this country, it seems like there's 4,500 different ways to process patients. Yes. There should be like 5 ways for whatever reason. But it seems like there's very little consistency, best practice, pattern behavior in the way we process patients. I'm not even talking about the individual interaction physician to patient. I'm talking about all the stuff that goes on behind it: lab work, radiology flow, admission processing, bed assignment, housekeeping, security, linens, all that kind of stuff. And there's as many ways to skin that cat as there are hospitals in this country. And it's so striking to me that in a sophisticated environment like this, when I talk to people about healthcare and the shortcomings in the same way you do, I oftentimes say, if you brought somebody from another planet to America and you showed them Wall Street, they'd be very impressed. Say, wow, 21st century. And then you took them to an assembly line in Detroit and showed them how we make cars. They'd say, that's beautiful, well done. Then if you dropped them into the healthcare system and show them the infrastructure we have from an IT perspective, for example, they'd think you just took them back 30 years in time. And I oftentimes use the analogy, the automobile assembly line. I feel like, as using an EMR and an ER, I feel like it slows me down, provides worse care. And now, granted, eventually, in 10 or 15 years, we'll get there. But I'm in the far left black and white photo you had there. I feel like I still have to push the automobile half the time. It's more efficient for me to pick up a pen. I don't really have a question here other than to say that everything you said is fantastic. And as a provider of healthcare, this is so abundantly apparent. We're spending 18% of our GDP on healthcare, and we should be spending, I don't know, 30% less for better quality if we could solve a lot of the problems you're encountering. If you can do it in your lifetime, I'd be impressed.
So how many of you does it terrify to find out? Here I'm saying, and another physician is saying, that behind the scenes, the work inside of hospitals is highly non-standardized. Isn't that sort of terrifying, right? I mean, it should be terrifying. You know, we have lots of safety and quality problems in hospitals. People are getting hurt and injured every day, and it's because of this lack of standardization. I hold my colleagues very responsible for this because we behave like artists, and we don't like anyone to impinge on our autonomy. We most prize our autonomy. So you can go into the OR and meet a team of like 8 orthopedic surgeons that are all part of the same department, and every single orthopedic surgeon wants an entirely different tray set up for their surgery, and they all use entirely different hips for their surgery. Well, can you imagine how confusing that is to be the OR technicians and the purchasers, and what variability and chaos that causes in the organization? They should be able to get down to the point where they say, for these kind of patients, these are the hips we use. Order lots of those hips. Let's all get really good at this one kind of hip, and let's all set our trays up and come to some agreement so that people aren't making mistakes. You know, for the techs to be setting a different tray up every other day is incredibly complex. It's unnecessary complexity that leads to lower quality, and it leads to errors and failures about, you know, you leaving a sponge in someone or leaving an instrument in someone. At the heart of it is physicians' way they're trained and our notions of autonomy, that we are the leader of the team, we're the boss, we tell everyone what to do, you know, to the point that our staff are intimidated by us and won't speak up. So we have extraordinary hierarchy, and that hierarchy is actually dangerous hierarchy, and it's damaging. We're creating this hierarchy by overpaying physicians. We're creating this hierarchy by giving them I think way too much privilege in society. And one thing we learned from lots of scandals in the last 20 years in our society is when you elevate any group, any professional group, and put them on a pedestal, they will abuse the privilege. That's just human nature. So the other problem in medicine and medical training is that we're not a scientific discipline. If you look at how we actually train doctors, we are a much older discipline that bypassed the Enlightenment. So it is a Greek tradition of fealty to authority, doing what you're told to do, and moving up through a gradual hierarchy and an apprentice model that is a very, very old model. And it worked great when it was just about watching your elder do something and copying from them. If you question authority on rounds, you will be squashed. So that's not a liberal critical tradition. I mean, the Enlightenment was about creating a liberal critical tradition, and there's a small number of doctors that are actually doing that are true scientists. And huge numbers, just really don't even understand the scientific method and are not using liberal critical thinking. And that's a lot of what you're seeing, I think, as well. So these are some really deep pedagogical issues about the history of medical education, how it got put together, and how our field is framed. So.
We have a question in the back.
Oh, yeah. Pooja Rani. I work for Peggy for another program called the Rockefeller Aspen Diaspora Program. I'm a patient, so I don't come from the healthcare field, but two questions. One is about EMRs. So I know EMRs are better for patients, but the question is, how would you get access to the same kind of information you had with these 3 hospitals and other communities, given the reluctance by doctors? For example, this gentleman in front talked about his reluctance to use EMRs. So how do you get access to that sort of information about different patients and their medical records? And then the second question is, could, instead of nurses in a structured environment, would hospitalists at all work on solving this thing? I'm not exactly sure what a hospitalist, all of a sudden all of my friends are like, I'm a hospitalist. I'm like, okay, whatever that means. So is that some sort of thing that's going in this, is that trying to fulfill these, kind of bridge that gap and inspire more collaboration, or is that something that's just a temporary Band-Aid solution?
So let's start with the EHR. EHRs got rushed out of the lab without any good research to know how to construct them, how to create the interfaces, and then how to train docs to use it properly and how to scale it up. So we had a stimulus bill, we poured billions of dollars into it and just rushed it out. And what we're finding out now is that it has a lot of unintended consequences and it creates new kinds of errors. So let me give you an example. A large unnamed hospital sent out an email to all of the medical staff saying, please stop cutting and pasting notes from the hospitalization every day. And essentially what was going on is that the busy residents were taking yesterday's note, cutting and pasting it to today, and not changing a lot of the stuff. And that's called cloning records, essentially. So what's happening now is if you request your medical record, it's about 1,000 times longer than it's ever been, because the EHRs have been tweaked to maximize the medical billing codes that you can charge. But the density of actual information in there is actually quite small because the docs are not actually typing anything, they're using templates. So there's some pretty big flaws about how EHR was created and very little data to show yet that it's beneficial to patients because we rushed it out of the lab before we knew what we were doing. To fix much of what I'm describing, we don't need EHRs and we don't need full-blown HIEs. The only thing we need is one data element, which is called an ADT feed, which is just the identity of who's been admitted to the hospital and the day they're admitted and the day they're discharged. So if all I had were that, I could solve 3/4 of this. So I need to be able to show up at the hospital the same day the patient's admitted because that's a wonderful critical moment in their life. And if I can get my team right up there the day they're admitted, build a relationship with them and work with them and get them out of the hospital and then stick to them like glue for 90 to 120 days, go to their home within 36 hours, go with them to their primary care appointments within 7 days, with them to their specialty appointments, help them get things kind of resituated in their life, then we can keep them out. But I don't need it, there's the icing on the cake and there's the perfect, and then there's just like basically what I need right now. And the bulk of the work I do could be done with pen and paper. it's accelerated and made more efficient by the electronic tools we use. So all my staff have pads in the field, and there's no commercially available software that really does any of the kind of stuff that we do. So we have sort of a homegrown database system where we collect about 450 different variables on each patient, and every time we touch them, we record who touched them, how long we spent, what we did, so we can track that and use it for operational improvements. But the kind of stuff we do, the tools are kind of way behind on. And then some of the tools are kind of unnecessary as well. Your last question about hospitalists are, doctors like me hated hospitalists when they first came in. So I was old school. I was going to go into the hospital and deliver babies. If you got admitted, I was going to show up at your bedside. And, my wife and kids got fed up with that. And I don't know if that was the best care. So that's old school care where the same doctor that takes care of you in the office takes care of you in the hospital. But hospitals are really complicated places. And I wasn't up there enough to keep tabs on everything that was changing and what was going on. So the hospitalist stays in the hospital, just cares for you in the hospital. Primary care doc just stays in the community and cares for you in the community. Primary care offices are really poorly run. I think people like me should just focus on making those offices run better. And then hospitals are really poorly run. Hospitals should stay in the hospital and fix those places and get them better run. I don't think moving back and forth in the long term is efficient or going to be effective. Yeah. I'm sorry, one question back here and then we'll go to you. Yeah, go ahead.
Hi. Hi, I'm Meryl Chertoff, Director of the Justice and Society Program. Dr. Brenner, first of all, I want to compliment you for the work that you've done in Camden. Before Cooper built all those fancy buildings there, I know that it was a really challenging environment to live and work in. So I want to compliment you for that. On the theory that healthcare is local as politics are local, I want to ask you a question about the effect of Camden's proximity to Philadelphia. There is a highly served community 5 minutes from downtown Camden. If you were the king of the world and you could restructure things so that the impediment to people receiving certain types of care in Philadelphia who are resident in Camden and the Camden area, if those things disappeared, what impact would that have on service to Camden residents?
I mean, the first thing I would do in Philly, we have 4 academic health centers. I mean, that's like an incredible feat of nature. It almost defies the laws of physics and gravity that you can fit that many academic health centers in one small community. I would close 2 of them entirely because we don't need them. And the more services you provide, the more unnecessary things you'll do to people and the more costs you will drive up. We don't need new money in healthcare. We just need to move the money around. We spend way too much money on healthcare in America. The other point to make in all this is that has anyone seen the book, The Healthcare Paradox? It's a wonderful book. It's one of my favorite books right now. And they make the point that if you had up social service spending and healthcare spending all over the world, the US just falls in the middle. But if you make a graph of the ratio of medical spending to social service spending, we're off the chart. So essentially what's going on compared to other countries is that we are medicalizing social problems. And the money that's going into the medical system should be going into all of our other systems. And by not spending in those systems, people are getting sicker, more dysfunctional, and ending up in the hospital. So, I think at the core of the answer to your question is that we should change how we're spending our precious resources and spend them more wisely. I'm sorry, you had a question?
I think I still remember it. I want to begin by saying, since there may be healthcare providers in here, that there's an interesting practice. I'm Garrett Mitchell, by the way, and I write something called the Mitchell Report. And I noticed that you call doctor's offices, no matter where you live, the phone is answered by a machine that gives you a lot of essential information, phone numbers, addresses, hours, doctors, et cetera. And when it's through with that, it goes on to say, if this is a healthcare emergency, hang up and dial 911. And I just thought maybe if there's anybody here who can influence that, that might be the first thing to say, not the ninth. I was struck by your definition of population health. which is better care at lower costs for everyone everywhere, if I got that right. I would venture to say that that the creators of what we still call Obamacare would say, right, that's what the Affordable Health Care Act was all about. My question is there, in your view, does the Affordable Health Care Act, as it currently is structured, move us in that direction, and is it something that you see as a positive development, or are we being misled?
I think the Affordable Care Act deserves incredible credit for moving us about 15 yards down the field. There's no way that you shift a system this complicated overnight. And there's no way that one law can possibly fix all the failures. But I think directionally they made some very smart decisions. So there's a $10 billion innovation fund. We've been funded through that. Other sites have been funded. And I think there's a lot of very fertile stuff coming out of that. The Medicare ACOs and the Pioneer ACOs sent a really clear market signal to hospitals that the world was going to change. Hasn't been perfect, but I think we're going to learn a lot out of that. There's been new payment methods of episode of care and all these interesting payment modalities that's helping. There's been penalties for readmissions that came out about the same time. That's been powerful and is sending a signal. Also, I think it's really hard to construct a sensible system when a big portion of the population just simply is not covered. I think it's very hard to solve the kind of problems that I'm solving when people go on and off insurance and you can't get your hands around what's going on. So, they end up, if they go off insurance, they end up with amputations, kidney failure, heart attacks, because there's gaps in their treatment and gaps in their care. So, I think we're just at the very first step of rationalizing the system. What I worry about is that we have 85 million baby boomers headed on a freight train to the most expensive system in the world. Cost half flattened out, which is amazing. But, boy, we're not ready for that. They're going to just hit us pretty hard. And, there are just not going to be enough doctors to care for them in the same wasteful way that we've always cared. We're going to have to really make transitions to the system. The interesting thing about the baby boomers is that they have changed every system they ever touched. They changed high school, they changed college, they changed being a young person, they changed marriage, child rearing, they changed work. They're going to change death and dying and aging in ways that I don't think we've even come to imagine yet. It would not take much for them to just stand up and have a change of taste and preference to blow up the financial model of a lot of hospitals. I mean, there are projections about how many hips they're going to get, how many knees, and you don't have to fall very much below the caring threshold of these systems to really start to, as GM found out, some shift in preference can really tank your business model. So, yeah.
Yes, one issue you haven't addressed that I would like to hear your comments on is the. Pardon me?
Can you introduce yourself?
Oh, I'm sorry. I'm Larry Stanton. I'm a retired physician, very interested in these topics. But you haven't addressed the topic of fraud and contributing to the overall health cost. And I would just cite as a possible example the woman that had 143 admissions and 70-some CT scans in a 2-year period. From a medical standpoint, I would say categorically that there was a profit motive involved. And I think that if we just address that one issue alone and put some of these people in jail, which is happening, I might add, more so. But I'd like to have your opinion as far as the system that you're most intimate with as to the contribution of fraud.
I think the biggest problem with the system is that there is no one answer. I mean, this is such a complicated system that you could do perfect fraud control and catch every bad guy out there, and we'd still spend too much money and still have a broken system. You could completely fix the malpractice system, and you'd still spend too much money and have a broken system. So let's take malpractice just for a second. So we have 50 states. They have state laws, and a few states have done pretty radical fixes to malpractice. And we've had a chance now to watch. And you would assume that places like Texas and California would have different cost trends because of that. And that's not what's happened. So you can fix your malpractice laws, have really deep caps, and have no impact on cost trends. So it's absolutely true that defensive medicine is a bad thing. It's true that the tort system is totally unconnected with fixing healthcare. It doesn't fix healthcare the way we do it. But costs in healthcare are being driven by so many different variables that are synergistic and complex that there is no single silver bullet. And I think fraud's a variable, but it's not the big variable. I think the big variable here, or larger variable, is the culture of medicine. And I don't mean the patient side of the culture. I think the doctors, the hospitals, the industry, this culture of what we do and how we think about our jobs is probably a bigger variable. So, great question. Yeah.
Hi, I'm Emma Lape at the New America Foundation. My question is about what you talked about at the end, industrializing the healthcare system.
Mm-hmm.
And I thought that was really interesting. I was wondering what you think about the relationship between that and sort of this movement toward personalized medicine on the biomedical side, becoming
Mm-hmm.
increasingly focused on treating people as complete, unique individuals.
Mm-hmm.
And how do those two interact, and how can we make our system work better for everyone instead of focusing on a few individuals?
That's such a good question. So let's tease that apart, because I think it's a really important point. There's wonderful work being done in personalized medicine, which says that your genes and your genes and your genes and your genes are different. And if I give you all the same medicine, it's going to have totally different effects. Some of you may die from it, from a side effect. Some of you may metabolize it differently and need a different dose. And that we can prevent a lot of harmful effects by personalizing your treatment to your genetics or to your metabolism. That's really powerful. That's just a powerful framework. But over on this other side, I just said we need to industrialize healthcare, and industrialization is standardization, protocolization, and it makes you think you're going to get you're just a number in an assembly line and no one's going to pay any attention to you. So I would argue, so I'm going to say it first in business terms and then I'm going to translate it. So we need to micro-segment the market of patients so that every segment gets their needs perfectly met. So that's both, because you're going to have a lot of standardization built in that, but you're also going to have a lot of segmentation so that the needs of different categories of people are met differently. So we do that all the time, like Procter & Gamble and GM and all the auto manufacturers. Like the clothes that you are wearing right now are not an accident. There is a person on, up in the advertising bureaus of New York. There is someone in the marketing company of where you shopped who know all about you. I know each one of you are special and you're all a unique individual, but you all have tastes and preferences and you've all been micro-segmented. When you get that mail, you're not getting random catalogs. Someone knows what your taste and preferences are. The Obama campaign micro-segmented. That's partly why they won. If you got an email, if you got a door knock, they knew exactly who you were and what message would resonate with you. They have very exquisite method to do this. If you didn't get a door knock and didn't get an email, that wasn't an accident. That was also microsegmentation. When capitalism segments, it's about efficiency. It's about not wasting time giving you a product, selling you a product, or introducing you to a product that's a total mismatch for who you are. So segmentation makes capitalism more efficient. But then behind the segmentation is a focused factory. It's a place where raw materials come in on one side, product comes out the other side, and it's highly standardized, highly protocolized to deliver the color, shape, and size of a high-quality product to serve exactly your needs. So you can actually have both customization and individualization through microsegmentation and have high quality through making sure that where those products are coming from is highly structured. So the answer isn't personalized medicine versus industrialization. The answer is both, which is it's not just one person in the country that can't metabolize Coumadin. There's actually thousands and thousands and thousands of them. They make up a microsegment. We sure as hell better know who they are so we don't kill them when we give them Coumadin. So, it's possible to have both of these, and that's the brilliance of capitalism, is that We figured out how to do that. You know, when you go to the Nissan dealer, you can buy an electric car, you can buy a gas car, you can buy a big car, small car, red, blue, green, yellow car. Like, that's incredible, the variety that you can buy. But those damn cars are high quality, so much higher quality than they were 30 or 40 years ago. So you can have both, I think. Yeah.
Hi. Thank you so much for your talk. You've raised so many questions in my mind. My head's kind of spinning right now. My name's Donna Cohen-Ross. I'm with the Center for Medicaid and CHIP Services. I'd like to bring you back to the beginning of your talk and ask you if you would say a few more words about your organization, about the coalition, and sort of what role that you all played in the city of Camden, and particularly if you could say something about the role of consumers. I think you mentioned that you had patients as part of your organization, and I'd be really interested in what role they played and how they function within the organization.
Thank you for asking those questions. So the coalition is about 51 full-time staff, 10 AmeriCorps volunteers. We have about a $5.5 million budget. We're a membership nonprofit, and we re-elect our board executive committee every year. We have a whole sets of different committees, quality committee and HIE committee, and we grab talent and energy from all over the region and pull them in. It's very much a coalition model. It's an engagement model. And like, I've got the IT departments of all the hospitals like deep in the mix helping us build this HIE and run it. We've got the finance people, CFOs and finance people from all over the community pulled together for our finance committee. We've got quality people pulled together for quality. And the hypothesis is really that fixing healthcare is a community problem. The frame of this, there are still fixes that have to happen inside of each institution, but the problem I'm solving of high-cost complex patients, you could be a perfect hospital and still fail, a perfect doctor's office and still fail, because this is how the homeless shelter connects with the behavioral health, connects with the addiction, connects with the church. Like, so you have to have an umbrella. Also, for the data sharing that we're doing, you have to have an umbrella. And I think for the financing model, you probably need an umbrella. So one of the things we did a couple of years ago was pass legislation that created a Medicaid ACO demo model in New Jersey. And it basically embodies our legal structure. And you have to have a membership nonprofit. You declare a geography. You have to have everyone playing. If you deliver better care at lower cost, you can capture the shared savings. So we're currently in a contract with United Healthcare using the frame of the legislation. One of the things the legislation does is pierce the Sherman Antitrust Act. Because one of the things that messes up our model is that we have set these institutions against one another with the incorrect idea that you will improve quality and reduce cost by having vigorous competition between hospitals. And it is largely not borne out. And it's certainly not working for poor people. I mean, they're just running away from poor people. So, so the way the legislation works is there's a state action doctrine. There's a Supreme Court case that says that a state can stand in the middle of an intervention and shield the intervention from the Sherman Antitrust Act. So we are colluding, my board colludes to deliver better care at lower cost for poor people. I don't know how else to do it, and the state stands in the middle of it and shields us from that. So we needed a legal framework in which to do this. So the things that the organization does, we run the HIE. We've got about 20 staff out in the field doing care coordination. We're deep inside of primary care offices doing redesign work. We've got a very sizable process improvement team that are doing operational redesign on whole pieces of the intervention in the system. A research team, because we've started a randomized controlled trial to test our intervention. So we have a bunch of different parts of the organization. We have something called cross-site learning, which is working with about 25 communities across the country to replicate the model. And we have learned so much about what works, what doesn't work by watching uptake in other places. It's, I think we're beginning to understand if there are laws to population health, like what they might be through collaborating with these other communities. There is a sweep of work going on across medicine to figure this work out right now, and we've managed to meet a lot of those people around the country. So.
I thank you for your talk. I really learned a lot and appreciate the complexity of the system. My name is Jessica Herstein. I'm an internal medicine physician, and I serve on the United States Preventive Services Task Force, where we set evidence-based guidelines for clinical services, including screening and counseling services. And in addition to the whole picture that you paint very convincingly of the lack of integration and the lack of human interaction and all the other complex factors you describe, what role does the fact that we have a lot of data, we know the science of a lot of these diseases and conditions and processes, and yet we're not getting it out there and people aren't following them. The healthcare system's not paying attention, despite all of our efforts to convey the knowledge and to use really accurate evidence-based science. They're out there, but they're not being used. Is that part of the problem, and to what extent?
So first of all, you have a much harder job than I do. Just to catch everyone up, the U.S. Preventive Health Task Force was the organization that ended up in the controversy about mammograms working or not working for people 40 to 50, which was like a lightning rod. And absolutely accurate as well. So I think it goes back to how doctors are trained. I think if we actually sat down and gave most doctors a quiz of what sensitivity, specificity, had them read a few articles and tell us what their understanding of it is, I actually don't think they'd understand most of it. The training that they get in med school, biostats and epi, to read the literature is very poor. They don't get enough practice of it, I don't think. The literature is much harder to read than it used to be, frankly, so I think that's a problem as well. And I'm still convinced that the core pedagogy of medicine is not critical thinking. It's do what you're told. And that feels to me like if you pulled all the lids off, that would be the deepest one. I'm optimistic. There's been a movement of field through internal medicine to talk about cost and, the list of things not to do that I think's been, tell me what the name, Choosing Wisely. Yeah, I love what they've pulled off. They basically made a giant list for every specialty of something you should never do. And that hasn't even worked perfectly. I mean, it got the conversation started. So, but thank you for the question. Yeah. Great. Thanks a lot. Thank you.
Thank you so much to all of you for joining us today, and thank you so much, Dr. Brenner. Jeffrey, your work is incredible. Ruth and I were just sitting there and kept saying, he's really smart, he's really smart. And to me, you fall in the category of people, which is the broad frame of this connects to that. And, some of the most breakthrough work of our time is people who can work across disciplines. And in the little bit of time I had with Dr. Brenner before, he talked about how when he started working in Camden, he was a doctor, and he was there to deliver babies and do those things, but he said he called himself a nerd, and he began reading everything he could about urban policy and social policy to try to understand what the hell was happening where he was working and what he was seeing. And I told you then, and I would like to say on behalf of us all, that at the Institute we're very, very supportive of your work. We're enchanted by your work. Others wish they could be here today to listen to you, and so we hope this will just be the first. But anything that we can do to support your work in Camden and your thinking personally, we very much like to do. So a round of applause for Dr. Brenner. Thank you. And I want to say this is the very first of our Aspen Institute Public Health Grand Rounds. Our next one is scheduled for November 17th with Dr. Tom Frieden, the head of the CDC. We'd love for you to join us. We are just building, Ruth's program and my program, just building this set of conversations. We'd love to hear from you about how to make this more effective for you. Please let us know other people to add to the mailing list. We'd like this to be a really wonderful collaborative discussion. And thank you all for joining us today. Dr. Brenner, congratulations on your work so far, and we really look forward to supporting you in the years ahead. Thank you.